matter. It looks like it works.
Well, it works. Thanks. All right. Have a good weekend.
Thanks.
All right. Bye, everyone. You'll be getting more emails from me as well. Thanks.
Bye. All right. So it looks like this is our last lecture of the series. I hope everyone has learned something so far from head and neck pathology. I believe that I haven't yet spoken about salivary gland, so that is going to be the last topic today. As usual, please type in the chat or pipe up if you have any comments or questions. Are all of you guys leaving this year, or is anybody sticking on for next year?
Yeah,
Leaving.
we're all leaving.
Okay, all right. Well, good luck to you all. And if you have any questions about head and neck path, please feel free to reach out to me wherever you guys are.
It's me, Mohammed. I'm going to rush because I have to do the 40-year pathway.
Okay, cool.
Me too, to Brigham and Women's in Boston, same
Oh,
thing.
nice.
I'm staying here in Illinois, more towards the south,
Uh-huh.
joining private practice.
Okay, cool.
I'm going back home to Kansas, near Kansas City.
All right. Awesome. Well, thank you guys for being attentive audiences, and yeah, best of luck in your careers. And I will be giving, I guess, these lectures to the new crop next year, I assume. All right, so salivary gland. Basically, we will talk a little bit about salivary gland histology. We will talk about some non-neoplastic entities, but mostly we're gonna talk about neoplasms, because those are the most frequent things that we see, at least from the path side. So the types of glands include the major and the minor. The major are the parotid, the submandibular, and the sublingual. The minor salivary glands, however, are located pretty much diffusely throughout the upper aerodigestive tract, into the trachea, down into the bronchi, et cetera. So we could theoretically have salivary gland type tumors arising not only in the major glands, but in any of the minor glands throughout these areas. If we're looking at a major gland, the way to tell where we are is based a little bit, of course, on location, but certainly on histology. So the parotid is essentially all composed of serous acini that contain these purple zymogen granules that contain the predigestive enzymes. We have submandibular gland that is composed of a mixture of serous and mucinous, the serous being purple and the mucinous being sort of white. The sublingual gland and many minor glands as well are also predominantly or entirely mucinous. Again, you can see here the pale intracytoplasmic mucin. So our function is ranging from digestive enzymes to more of a lubricative mucoid function. Some of the common non-neoplastic entities that we see include a mucocele. And so this is a pseudocystic reaction to mucus extravasation in sites usually of trauma or lip biting. These usually wax and wane. And if they are quite large, they can actually be considered ranulas or plunging ranulas, where there are these large kind of fluctuant masses either at the floor of the mouth or even plunging down into the neck. These are lined by macrophages or so-called mucophages, meaning macrophages that ingest mucin at the cyst wall. And that's how the diagnosis is made, at least histologically. Interestingly, it's named based on the frog, who has this sort of gullet that is balloon-like, that looks very much like these bulging items in the sublingual area. So I thought that's interesting. Other bulges that are firm can be stones or cyaloliths. So these are most common in the submandibular gland, but really can be present in any ductal system of any salivary gland. The nidus is generally some kind of organic material that then sort of collects and collects and collects and starts to plug the duct. And so these patients present with pain and swelling, usually at mealtime, right? Because that's when the glands are trying to secrete digestive enzymes in and they can't. And so either surgery or lithotripsy is indicated in these patients. if the stone does not resolve itself. Occasionally, we see lip biopsies of minor salivary glands to diagnose Sjogren's syndrome, and that is defined as inflammation within the salivary gland of a focus of 50 or more lymphocytes / plasma cells. And so there is a scoring system that was developed, including with folks here at the U of C in the past. And basically, we look at these minor salivary gland lobules and identify these clusters of inflammatory cells. Basically, these are mostly done in patients in whom the serology or clinical picture is equivocal. And so then they get a biopsy to sort of try to push it into definite Sjogren's or not. Other findings in the salivary gland include atrophy or sialometaplasia or sialadenitis. And so anything that injures the salivary gland, like prior surgery, like chemoradiation for other tumors, like ischemic change, can result in a number of histologic changes, including replacement by a lot of fat or adipose tissue. You can see here in white, fibrosis, inflammation, but the general acinar structure in the background is retained. So you can see here there's a duct in the center with some lobules at the edge. That is the normal ductoacinar structure of the salivary glands. However, sometimes in extreme cases of injury, the salivary ducts and acini undergo squamous metaplasia, so transition from, serum mucinous to squamous, and so that's called so-called sialometaplasia or metaplasia of salivary glands to a squamous phenotype. Occasionally, it presents as a solitary ulcer on the palate, but you can also see it just sporadically, as I said before, especially in patients who have been chemoradiated for other cancers. And so this could be a potential confounding factor between squamous cell carcinoma and squamous metaplasia, especially in patients who have a history of squamous cell carcinoma. So if you ever hear us reporting on challenging cases or quote unquote sialometaplasia, we are concerned about it because of its resemblance to invasive squamous cell carcinoma. But there are ways to sort of tell the difference, including, as I said before, the maintenance of this ductolobular type of architecture, some residual mucinous cells, and some ductal lumina. Before we move into the full tumors, there are a couple, or at least one of these entities where it's kind of on the verge between, is it a tumor or not a tumor? And so if you think about conceptual neoplasia, right? A neoplasm or a tumor is a clonal process, meaning it derives from a single cell that has some kind of genetic anomaly that proliferates and creates a mass-forming lesion, versus a hyperplasia, right, which is a reactive process that doesn't have any underlying genetic changes. And so there's this one tumor called sclerosing polycystic adenoma, or sclerosing polycystis adenosis, that is one of these lesions that we are recently discovering to potentially actually be a clonal neoplasm and not just a reactive process. So these are basically proliferations of salivary ducts and acini that can be mass forming. And recently it was found to harbor P10 mutations. And so it's thought that this lesion that was formerly thought to be a reactive process might now actually be a neoplasm, not so much of a huge change in our understanding of the treatment of these patients, but more just an interesting thought on tumor biology and how we are learning things every day. We are learning how tumors are driven. We are learning the molecular alterations that occur in tumors. And so just something to keep in mind throughout this lecture and throughout our careers is that information and knowledge isn't static. It's constantly changing. And so keeping up with these, especially in the genetic arena, I think is going to be very important, not only for salivary glands, but for other types of tumors. So moving into what we currently know about tumors, their behavior, their morphology, their genetics, et cetera. In the salivary glands, benign tumors are much more frequent than malignant ones. And most commonly, we're sort of going to be dealing with, pleomorphic adenomas of the parotid, right? So if you think about a salivary gland tumor, that's sort of the prototype. But you can get benign and malignant tumors in all locations. Interestingly, the sublingual gland is the site that contains the highest rate of malignant tumors. for reasons that are unclear. But overall, salivary gland carcinomas are about 6% of all head and neck cancers, the vast majority of them, of course, being squamous, squamous of mucosal sites. So when we're dealing with benign tumors, the most common, as I said, is pleomorphic adenoma. The most common malignant is mucoepidermoid, followed by adenoid cystic. And we'll go over what each of these look like. But to sort of present an overview of how patients may be worked up, is once a mass forming lesion of the salivary gland area is determined clinically, by patient palpation, by swelling, by imaging, usually FNA biopsy is the preferred screening tool. So just like we talked about with thyroid, there are standard diagnostic systems that have been developed for salivary gland, just like there are with thyroid. And so anywhere from, non-diagnostic, I really don't know what's going on, to non-neoplastic, oh, this is certainly, sialadenitis, there's tons of inflammation, okay. Or all the way to, yep, this is definitely fitting the pattern of a neoplasm. This is definitely fitting the pattern of a neoplasm, and I'm worried it's cancer. And yes, I'm certain it's cancer. And so depending on, what diagnosis you get on FNA biopsy, you may undergo just clinical follow-up, repeat FNA, but most often a surgical resection for something that is definitively neoplastic. Remember, in the thyroid, that system was called Bethesda. In the salivary here, it's called Milan. Again, just based on the location where these groups met to create the breakdown. So here are some examples on FNA of what might be a non-diagnostic specimen. So something like, I only see cyst contents, like some grungy material, some macrophages. I don't know what this is. This could be a cystic tumor. This could be a benign cyst, uncertain. Also non-diagnostic is just normal salivary acini. If you're targeting a lesion and all you get is normal, then the lesion was probably missed. And then lastly, chronic inflammation or chronic sialadenitis, depending on the clinical picture, if it's diffuse enlargement of the gland, could be diagnostic, but if there's a mass forming lesion, then just seeing chronic inflammation would not be diagnostic of whatever mass forming lesion that is. Here are some examples of what might actually be diagnosable as neoplastic, ranging anywhere from adenoid cystic with this classic so-called bubblegum colloid. It looks like those old, 1970s, 80s, like big chewing bubble gums. Also pleomorphic adenoma with these bland strips of cells and this kind of more fibrillary magenta matrix. There's Warthin tumor that is composed of both oncocytes and lymphocytes, and then mucoepidermoid carcinoma, which contains neoplastic cells containing mucin, as well as perhaps some extracellular mucin. So these are just examples of what we might see that could render a specific diagnosis on an FNA. But many times a diagnosis is not specific to a type of tumor. Sometimes it's just specific to a tumor. So you may see, a diagnosis on FNA such as neoplasm or basaloid neoplasm, in which, the features between some of these cannot be sorted out clearly, but it's certain to be a tumor. It's just not certain what type. So those will certainly go for diagnostic resection, diagnostic and therapeutic resection. So once we have a diagnosis of a neoplasm based on a biopsy, we want to sort of understand, is it a primary parotid neoplasm or is it a metastasis? I'm saying parotid here because that's the most common site we're dealing with, but replace that with any salivary site, right? Is it a primary salivary site or is it a metastatic? Especially in the parotid, in the submandibular areas, there are intra and periglandular lymph nodes. Therefore, metastasis to those intra or periglandular lymph nodes from other sites, such as squamous cell of skin or melanoma of skin, can present in parotid or submandibular gland areas, et cetera. So always keeping that in mind. And understanding patient history can help sort this out. If we think it's a primary parotid neoplasm or primary salivary gland neoplasm, treatment will depend on whether it's benign or at least a low-grade neoplasm. So sometimes on FNA biopsy or on core biopsy, it is not clear whether it is a benign neoplasm or a low-grade carcinoma, mostly because we cannot evaluate the border of that lesion to determine if it's infiltrative. The good thing is both a benign adenoma and a low-grade carcinoma are treated with, surgical resection with negative margins and observation. The treatment algorithm changes once something is diagnosed as a high-grade carcinoma, and these patients are likely to undergo neck dissection to evaluate for lymph node metastases. The good thing is also on biopsy, generally there are features that can put a tumor into a high-grade pattern, like lots of mitoses, necrosis, increasing cytologic atypia. So there are features on biopsy that will generally help us draw this clinically important line between benign, low-grade, and high-grade. So once the decision is made to operate, then the role of the surgical pathologist is to again confirm a primary versus a metastasis, confirm low versus high grade, comment on the margins, and provide a TNM stage if it is in fact a carcinoma. Grade is sometimes often considered more important than the histologic subtype of salivary carcinoma, because the histologic except for things like adenoid cystic that very frequently have nerve invasion and are very hard to resect, most other salivary gland tumors, it's very important for us to at least comment on grade so that appropriate neck dissection can be performed and appropriate chemo and or radiation can be given. We're going to talk a lot about the various histologic subtypes of salivary tumors today. If you go out, when you're out in practice, salivary gland tumors, as I already mentioned, are rare, and it can be challenging for pathologists who don't see these very often to make definitive diagnoses. But I would argue that even if a definitive diagnosis is not possible, the most important thing, as I said, is to sort of discuss what histologic grade this tumor is likely to be. And there are common overlapping features that define high grade, as I said before: perineural invasion, lymphovascular invasion, mitoses, necrosis, et cetera, that will determine more accurate treatment for these patients. We're lucky at academic institutions to see, a lot of these and be very comfortable, or at least more comfortable with diagnosis. But they can certainly be challenging because the histologic features are very overlapping. Just to give you an idea of all the various types of tumors that we are dealing with, here is a chart. So you can see on the left where I've listed the benign adenomas. You can see on the right where I've listed the malignant counterparts. Some tumors are only benign. Some tumors are only malignant, and some tumors have both sort of benign and malignant variants, like basal cell adenoma, basal cell adenocarcinoma, oncocytoma, oncocytic carcinoma, et cetera, et cetera. So this is kind of how I understand salivary tumors. The other way in which I understand salivary tumors is by how many cell types they have histologically. Do they have two cell types, meaning recapitulating both the epithelial and myoepithelial components of the normal ductoacinar system? Do they have a single cell type, meaning recapitulating only the myoepithelial or only the epithelial subtype? Or do they have three, that unique one being mucoep, both mucinous, so-called intermediate, and so-called squamous cells? So diagnostically, the number of cell types for me is helpful, as well as genetically. So we now know a lot about the molecular genetics of salivary gland neoplasms, and in equivocal cases, this can aid in subtyping, as each of these unique histologies are determined to have unique genetics in many, many cases, and we will talk about those as we go. Then on the right, looking at grade, so most carcinomas can be either of low or high grade. There are very few that are only one or the other. I will point out, for example, something like a sebaceous adenocarcinoma or something like a salivary duct carcinoma are generally really only considered high grade. There isn't a low grade counterpart, but for most others, there are, and therefore grading of these, as I said before, is going to be important from the pathologic standpoint. So how do we look at these tumors when we first get them on the slide? So we start to examine the overall border, meaning is it circumscribed or infiltrative? Both low-grade both benign and low-grade malignancies can be circumscribed. However, an infiltrative growth pattern is the best indicator of malignancy. You really should not see infiltration in a benign tumor. We examine, as I said, the number of cell types, whether it be mostly one or two. So there are monomorphic neoplasms that are composed entirely of epithelial cells or entirely of myoepithelial cells. And then there are these biphasic neoplasms that are composed of both epithelial and myoepithelial cells. Once we've determined monomorphic or biphasic, we can put it into a morphologic pattern grouping and selectively use immunostains and genetics to determine which exact subtype of tumor it is. So we're going to start with the benign tumors and talk about some of their malignant counterparts in the context of the diagnosis, the number of cell types, and what they look like between benign and malignant. Pleomorphic adenoma, as I said before, is the most common. Grossly, this is sort of very white and very well circumscribed, often actually grossly resembling cartilage because it often has a very cartilaginous stroma. Now, you might ask, why is this called pleomorphic? We often use the term pleomorphism to describe cytologic atypia, meaning variation in shapes and size of tumor cells and tumor nuclei. However, it's a little bit of a misnomer. Pleomorphic adenoma isn't cytologically pleomorphic. It's architecturally polymorphous, meaning it can present in a myriad of architectural structures, which I will show you. But it is not actually cytologically pleomorphic. It is architecturally heterogeneous or polymorphous. And here are some examples of that. So the characteristic prototype is of a combination of both bilayered ducts with inner epithelial and outer myoepithelial cells set in a myxoid or chondromyxoid stroma. Within the chondromyxoid stroma are these single myoepithelial cells. So seeing something with bilayered ducts and cartilage or chondroid stroma is basically diagnostic of PA. The myoepithelial cell morphologies can, however, be very varied and very overwhelming. So sometimes a tumor is predominantly spindled, predominantly plasmacytoid, or predominantly small and conspicuous, only focally punctuated by duct-like structures such as this, hence polymorphous in architecture. Sometimes you can see these characteristic tyrosine crystals in the stroma. That is also helpful and diagnostic of a PA. What can PA do? Why do we care? Well, it can be a very scary tumor to deal with. It can certainly recur after incomplete excision in the form of multiple small nodules. Therefore, primary resection of pleomorphic adenoma should ideally be as clean as possible so that local recurrence is minimized. Because once it recurs, it has an increased capacity to transform to carcinoma X pleomorphic adenoma, so-called carcinoma arising out of a pleomorphic adenoma. So what does that look like? So recurrent pleomorphic adenoma looks like these multiple small, usually chondromyxoid stromal-rich lobules present as sort of, buckshot within the stroma. This is basically definitional of a recurrent pleomorphic adenoma with these multiple small lobules. Once it transforms, these are sort of by definition either a carcinoma with evidence of an adjacent benign pleomorphic adenoma or a carcinoma arising in the same spot as a prior pleomorphic adenoma that has been previously resected. Once these are invasive and destructive into the adjacent gland, they have high rates of metastasis and poor survival. If they are so-called still in situ, the prognosis is much better. So here's an example of what an in situ carcinoma might look like, such that you still have a very confined neoplasm. You still have this bilayered ductal structure, but within the bilayered ducts, you start to have increasing cytologic atypia with nucleoli. You start to have increasing mitoses, but these neoplastic cells have not yet broken through the boundary of the tumor. The boundary of the capsule, and these are so-called in situ. But once you have, again, this breaking of the boundary and invasive lobules into the adjacent stroma, here's your adjacent benign pre-existing pleomorphic adenoma on the bottom right. This is now a high-grade invasive carcinoma and should be treated aggressively. So again, on higher power, showing you a box here of the pre-existing pleomorphic adenoma from whence that malignancy arose within the ductal system. And then it started to invade outside on the top left into this invasive varicellular carcinoma. So that's how PAs transform. They transform within the ductal system and then they invade. I can skip this. This is all right. So the genetics. So most pleomorphic adenomas have involvement of PLAG1 or HMGA2, either rearrangements or in some cases mutations. So finding one of these rearrangements can define both a pleomorphic adenoma as well as a carcinoma X pleomorphic adenoma. If you have a tumor that is composed predominantly or entirely of myoepithelial cells without any ducts, these could be considered myoepitheliomas. These are very rare, but myoepithelial cells express both markers of epithelium, so keratins or epithelial membrane antigen, as well as contractile or myoid markers. So if you think about it, myoepithelial cells are the ones around the ducts and lobules, right, that sort of squeeze so that the ducts can exude the contents into the mouth or trachea or whatever. So these generally have some contractile filaments like smooth muscle actin, etc. So just conceptually, that is a myoepithelial cell. By definition, these are myoepitheliomas are not invasive and myoepithelial carcinomas are invasive. They can transform from pleomorphic adenomas, so-called myoepithelial carcinoma XPA, and some can just be de novo. Some myoepithelial carcinomas have EWSR gene rearrangement, especially if they demonstrate clear cell morphology. Here's an example of a myoepithelial carcinoma. These multiple highly cellular lobules with these strands of cells within a myxoid stroma, but there are no ducts. These are all just individual and clustered myoepithelial cells. The next most common benign tumor is Wharton tumor, which you will probably encounter quite frequently, especially if you're doing head and neck / neuroradiology, because these pop up in the parotids of people who are smokers. And generally, right, these people who are smokers may have developed some carcinoma in some other site, maybe head and neck squamous, maybe lung, maybe, colon, and so maybe bladder. And so they have full body scans, PET scans, and something pops up in the parotid. And because there's now a new tumor in the parotid, it gets an FNA, and it's often determined to be a Wharton tumor. For some reason, these like to occur in smokers. They are sometimes bilateral, and they are highly PET avid, perhaps because of their abundant lymphoid stroma or their oncocytic epithelial cells, which are extremely metabolically active. So here's what it looks like. It looks like these bilayered sort of ducts and cyst-like structures lined by these oncocytic cells with this excessive, abundant lymphoid stroma. Here at the top left, you can see the normal gland. So there's low rates of malignant transformation in these. Mostly they remain benign neoplasms. Just to remind you of what an oncocyte is, it's basically a swollen cell. The cell is swollen because it's filled with mitochondria, which makes it very metabolically active. All of these little tubules here are mitochondria. This is the nucleus on electron microscopy. Again, the mitochondrial rich cells, as well as the lymphoid stroma, may account for the PET avidity, as these cells perhaps take up a lot of glucose. Therefore, don't be surprised if you see a Wharton tumor in the parotid of someone who has some other cancer, especially smoking related. Does that make sense?
Yes.
All right, moving on to, thank you, oncocytoma. So oncocytoma is histologically differentiated from Wharton tumor essentially by its lack of lymphoid stroma its lack of cysts, but it's solid growth of oncocytes. You can sometimes see oncocytomas or oncocytic nodules in the elderly because they develop oncocytic metaplasia of their salivary glands, which sometimes develops into oncocytic hyperplasia and sometimes oncocytomas. So here's an example of an oncocytoma with a very clean border and just solid nests of these oncocytic cells. Again, no cysts, no lymphoid stroma, so different from a Warthin tumor. Here's an example of oncocytic metaplasia in the elderly, these little patches and nodules of metaplastic change that can transform to tumors. Oncocytic carcinoma, as you may have guessed, is differentiated by its infiltration. So if you look at the low power of an oncocytic carcinoma, you can see it has these tongues that invade into the adjacent, and sort of by definition, that is now a carcinoma. You can get random atypia in oncocytic tumors that does not affect the grading of these. As you can see here, these very large random cells. But grade is more often related to things like increased mitoses, necrosis, as I mentioned before, in the background of an otherwise oncocytic neoplasm. The next type of tumor that has both a benign and a malignant counterpart is basal cell adenoma and basal cell adenocarcinoma. Now, I will just point out that this is not the same as basal cell carcinoma of the skin. Basal cell carcinoma of the skin is histologically similar, but completely genetically and behaviorally different. So basal cell adenoma is a circumscribed neoplasm, which is very so-called blue or basaloid, because its cells have high large nuclei and low NC ratios. On higher power, you can see it's defined by these nests with peripheral palisading, by these very pink or eosinophilic basement membrane globules. Sometimes these have mutations in the beta-catenin gene, and so you can mark those by beta-catenin immunohistochemical stain. Basal cell adenocarcinoma, again, I sound like a broken record, is differentiated from an adenoma by infiltration. Basal cell adenocarcinomas are sometimes showing loss of the CYL gene, the cylindroma gene, which is the same gene that is lost in these patients with familial dermal cylindromas. You may have seen this as the so-called turban tumor. So CYLD gene is implicated in dermal cylindromas, as well as salivary basal cell neoplasms. Here showing that infiltrative growth in terms of the overall tongues that percolate into the adjacent tissue, but again, similar morphologic features of peripheral palisading and hyalinized basement membrane stromal material. A benign tumor that has a very characteristic clinical pathologic correlation of being present on the upper lip of older females is canalicular adenoma. This has a characteristic sort of almost double-stranded appearance here that I'm trying to highlight, these sort of tracts of cells with this myxoid background, sometimes with little percolating morules. So essentially, not much to say here for you guys, but this is a very characteristic, upper lip, older female type of tumor, very rare, but just that characteristic clinical pathologic correlation. All right, now moving into the tumors that are only malignant. So these do not have a benign counterpart. And so if you see something that matches this, it is by definition a malignancy, then it will be a matter of just grading. So starting with mucoep, the most common carcinoma, this occurs, don't forget, both in adults, but also in children. So this is one of the carcinomas that can occur in kids. We know that kids don't often get carcinomas, but if they do, they tend to be of, maybe thyroid, papillary, they tend to be mucoeps. So just something to remember. The genetics in this is CRTC1 or CRTC3 fused with the MAML2 gene. So basically, MAML2 gene rearrangement is definitional of mucoepidermoid carcinoma. It can be either solid or cystic on low power. And it should demonstrate whether it be solid or cystic, it should demonstrate all three cell types. It should demonstrate mucinous cells. It should demonstrate squamoid cells that resemble almost squamous cell carcinoma. And then these very nondescript, quote unquote, intermediate cells with sort of round nuclei and sort of pale cytoplasm. In order to determine if clearing within a cell is truly mucin or just glycogen, we sometimes apply a PAS stain. So you may see reports of PAS stains. Generally, that is to define mucin. So PAS binds both mucin and glycogen in cells. However, if you apply a digestive enzyme called diastase or amylase, the diastase will digest out the glycogen, but will not digest out the mucin. So so-called diastase resistant versus diastase sensitive. If you still see the staining after the application of diastase, this means this is intracellular mucin that will support a diagnosis of mucoep. If you have cells that have the substance digested out, that suggests that it might actually be glycogen and not true mucin. So this may more likely be like some kind of squamous cell carcinoma. Mucoepidermoid carcinoma is one of the most well studied in terms of histologic grade. There have been 4 proposed grading systems that range from quantitative to qualitative. Generally, they all result in 3 tiers: low, intermediate, and high. And those of you who've been on the head and neck tumor boards, you know that nobody likes the diagnosis of intermediate grade because nobody knows what to do with it. We have found that the AFIP system generally assigns tumors lower grades, and generally the Brandwein system assigns tumors higher grades. So if you were to grade, the same tumor across all systems, there are certain occasions in which one system might grade it low, one system might grade it intermediate, and another system might grade it high. And this is a significant problem in salivary pathology. However, we found that if something is high grade in the Brandwein system, it tends to actually have a higher risk of behaving in a high grade fashion. And if something is low to intermediate grade on the Brandwein system, we have found that it actually behaves quite indolently. So this is now where we draw the line between Brandwein low/intermediate and Brandwein high. Low and intermediate in this spectrum seems to actually be quite close in terms of prognosis and survival. Therefore, we think that if you have a Brandwein intermediate, you may actually monitor it just like as if it were a low. Therefore, we try to avoid a diagnosis of intermediate grade, or if we have to make it, at least stress that it's probably likely to be on the low end of the behavioral spectrum. So still work needs to be done for grading, but this is as good as we have for now. All right, moving into our second most common carcinoma, which is adenoid cystic. As I kind of hinted at before, this is frequently associated with perineural invasion, tracks up the cranial nerves to the base of skull, and can be very, very challenging to excise, very high recurrence and metastasis and mortality rates. So adenoid cystic is defined again by 2 cell types, by its patterns, which I will show you, and by its genetics. So many have rearrangements of NFIB with MYB genes, so MYB-NFIB rearrangement. The morphologic pattern is characteristically this cribiform pattern, or sort of sieve-like or Swiss cheese-like, with these punched out holes. You can see here on the bottom left perineural invasion, where it's just wrapping or hugging this nerve. Here are the 3 patterns. There's a tubular predominant pattern, there's a cribiform predominant pattern, and then there's a solid pattern where we go from, we think, biologically lower to perhaps biologically higher grade as we go from tubular to cribiform to solid. You can prove in most of these cases that there are 2 cell types. You can see the myoepithelial cells kind of in the outer part of the sandwich, and the epithelial cells compressed between the myoeps, here staining with c-Kit or P63. As I said before, tubular, cribiform, solid, but even beyond those 3 grades, there is a higher grade transformation that is so-called dedifferentiation or high grade transformation, where you can no longer even tell that this was adenoid cystic. So just for comparison, the solid type of adenoid cystic is seen on the left here, where the nuclei are still small and ovoid. You can still see a little bit of a cribriform punched out space here. And then on the right, completely different. The cells are open with large nucleoli, prominent mitoses. And the only way to tell that this was adenoid cystic was to perhaps see a pre-existing tubular cribriform or solid component in the adjacent area or genetics. So this is so-called dedifferentiation, which is even worse high-grade behavior. The next tumor, which sometimes resides on the histologic differential, is polymorphous adenocarcinoma. This most commonly occurs in the palate. It has a single cell type with these ovoid nuclei and is defined by PRKD1 gene mutations. So here's polymorphous adenocarcinoma. You can see again a single cell type. This also sometimes has perineural invasion, but we think does not behave quite as aggressively as adenoid cystic. And you can differentiate it histologically from adenoid cystic based on its lack of a myoepithelial cell layer by its lack of P40. There's a variant of polymorphous called the cribriform variant that is thought to exist in minor salivary gland sites outside of the palate. It's morphologically very similar, and it is in fact also genetically very similar, where it has PRKD gene rearrangements as opposed to PRKD gene fusions. Why do we separate these out if they're so similar? Well, interestingly, it's thought that the ones that match the cribriform variant actually have more frequent lymph node metastases than those that are of the conventional polymorphous variant. So just an interesting breakdown that we may be hearing more about in the future. Moving on to actinic cell, these tumors basically resemble just sheets of those purple serous acinar cells, and are generally low grade, but as with any other tumor, can undergo high grade transformation. There have been recent discoveries of some gene rearrangements. Here's an example of what it looks like on the top right, just basically sheets and sheets of those purple serous acinar cells containing zymogen granules, diagnostic of actinic cell carcinoma. Again, here showing high-grade transformation to a tumor with prominent nucleoli, many mitoses, and on the right, there's a small suggestion of residual acini from the actinic cell carcinoma. There are a few tumors in salivary gland that resemble breast cancer of various types and various morphologies. So I'm kind of grouping those here. You know, breast glands and salivary glands are similar structurally, similar morphologically, and sometimes even their tumors overlap. So this was one of the first that was described in resemblance to secretory carcinoma of the breast. And in fact, it is histologically and genetically identical. They both have this ETV6 NTRK3 gene rearrangement. Secretory carcinoma of salivary gland tends to be well circumscribed or multilobulated, and it has a number of architectural patterns, including these microcysts with intraluminal secretions, including these papillae with intracytoplasmic vacuoles, and are usually diffusely positive for S100 and mammoglobin, mammoglobin being sort of a breast marker, which we as pathologists can use to help in diagnosis. This can undergo high-grade transformation with, you know, as usual, PNI, LVI, necrosis, mitoses, et cetera. The next tumor that resembles breast cancer is considered salivary duct. These can arise de novo or out of a pleomorphic adenoma. So salivary duct carcinoma ex pleomorphic adenoma. These are by definition high grade. There really is no low grade salivary duct carcinoma. And this resembles high grade ductal carcinoma of breasts with apocrine-like morphology. I will point out here that androgen receptor is generally positive in these, and HER2 is frequently amplified, which can be used as targeted treatments. They should, however, be negative for ER and PR, estrogen and progesterone receptors. If you do have strong ER, PR expression in a salivary tumor, this is more highly likely to be a metastasis from the breast, because primary salivary gland tumors, even if they resemble breast, are ER, PR negative. So just keep that in mind for treatment purposes. Here's what salivary duct looks like. these large nests with these punched out spaces with central necrosis, with an apocrine-like morphology, with perineural invasion. Here's showing you an example of nuclear expression of HER2 and membranous, nuclear expression of androgen receptor and membranous expression of HER2, which of course can be treated with, androgen antagonists and Herceptin. Next one is intraductal carcinoma, which resembles low-grade ductal lesions of the breast. So like low-grade DCIS or ADH. And in fact, these are actually not invasive. Intraductal says it all. So these carcinomas proliferate within the ductal systems and do not invade. So how do we decide that? So you can see here a minor salivary gland site with overlying squamous mucosa. You can see this glandular cystic proliferation in the bottom, but every single one of these cysts is lined at the periphery by a layer of myeloepithelial cells with SMA staining and with P63 staining, and the tumor is proliferating only within the lumen of these ducts. And so this retention of the myeloepithelial cell layer, in this case, the myeloepithelial cell layer is thought to be not a component of the neoplasm, but is thought to actually be the residual myeloepithelial cell proliferation, myeloepithelial cell layer of the normal ductal system. And the proliferation is only within the ductal system because these actually do quite well. They don't really ever metastasize. And that's thought because they're not actually invasive. They are intraductal. Okay. Moving on to epithelial myeloepithelial carcinoma. Again, I like some of these names because they sort of tell you what they are. So epithelial myeloepithelial carcinoma is a carcinoma that is combined epithelial and myeloepithelial cells and is related to HRAS mutations. So in most epithelial myeloepithelial carcinomas, the myeloepithelial cell population predominates. And you can see here these sheets of solid cells. These are actually the myoeps. And the only epithelial cells are these occasional ducts, as you can see here, duct. And these are generally high-grade carcinomas. They generally have central necrosis and an infiltrative growth pattern. So that's epimyoep. Pretty rare, but you may see it on occasion. One type of tumor that we're also learning about is clear cell carcinoma. As you can see, the cells are in fact clear with very dark wrinkled nuclei and with sometimes an eosinophilic or hyalinized bands separating the lobules of tumor cells. This interestingly stains exactly like a squamous cell carcinoma, but is thought to be a tumor of salivary gland origin because it occurs both in salivary gland sites. And interestingly, it also occurs in intraosseous sites. And when it occurs primarily in the bone, is sometimes referred to as clear cell adenogenic carcinoma, as opposed to clear cell salivary type carcinoma. However, the morphology and the genetics are identical, the genetics being rearrangements of EWSR ATF1 gene. So by definition, clear cell carcinoma of salivary gland. Sometimes we have these rare birds in the salivary that don't quite fit other salivary primaries. There is one tumor called so-called lymphoepithelioma-like carcinoma that morphologically resembles nasopharyngeal, meaning it resembles a non-keratinizing squamous cell carcinoma with lymphoid stroma. Some of them actually are related to EBV. I'm not quite clear whether these end up actually being metastases from nasopharyngeal carcinomas or de novo in the parotid, but just be mindful that these types of tumors can in fact occur in the gland, and here's what they look like. Just syncytial, large pleomorphic cells with background inflammatory population. In this case, the P63 highlighting the tumor cells, and you can see how many cells in the background are negative. Those are all the inflammatory cell population. You can also get conventional keratinizing squamous cell carcinomas of the parotid. However, these are more often than not metastases from cutaneous primary sites. And we have proven that in this institution by the high rates of ultraviolet signature mutations that have been found in squamous cell carcinomas of the parotid. What is ultraviolet signature? So UV signature is C to T or CC to TT base pair changes in the DNA of these tumors in numerous sites throughout the DNA of many genes. And this is a known consequence of ultraviolet sun exposure. So when you find this genetic change, you can be highly certain that this arose in a sun exposed site. Now, the UV signature isn't specific for squamous cell carcinoma. You can get UV signature in squamous cell carcinoma, melanoma, right? Even some dermal sarcomas that are very superficial in the skin. But the morphology combined with the UV signature will tell you that this is a metastasis from a cutaneous site. Generally, these patients who are metastases from cutaneous sites do better than those that are primary parotid squamous cell carcinomas or even extension or metastases from mucosal squamous cell carcinomas, which do worse. So yeah, I think that's all we have for salivary. Again, we're a little bit early, so hopefully you guys found some of this helpful, and I'm happy to have any questions if you have them.
Thanks for
Thank
your
you,
lecture.
Cipriani.
Thank you so much.
You're welcome.